Lindsay.
That sounds good.
Okay, great. All right. So welcome everyone to the first statewide Children's Committee meeting of 2022. It looks like we have 19 participants on the call, which is great. I appreciate you all taking time out of your day to meet with us this morning. As you can see, we're still meeting virtually, and this is per the Open Meetings Act. With the new variant, which is highly contagious, going around, we felt this would be the best option to continue doing to make sure everyone is safe, and something that we'll discuss again every quarter just to see where we're at. The ultimate goal is to make sure that everyone is safe. With that being said, please make sure your phones and or computers are muted if you're not presenting. It just helps to prevent any feedback from coming through. And please also state your name when asking a question or commenting. It's helpful when capturing the minutes. If you have joined via phone and you're speaking and it's not coming through, hit *6. Sometimes it mutes automatically and sometimes it doesn't. So if you're speaking and it doesn't come through, try hitting *6 first, and it should come through. I also, you'll notice in the email that I sent out, I've also included the minutes from the November 2021 meeting, which seems like forever ago. And those minutes were also shared via email in November. So you should have all had a chance to take a look at them. We are going to go through each person on the call and vote to approve the minutes. So what I'm going to do in order to save time is, as I go through attendance today, if you can please state yes, no, or abstain as it pertains to the November 2021 minutes. That could save us some time. Just a reminder, if you are department staff, you will need to abstain from approving the minutes. So, like I said, my name is Kirby Fye. I'm with the department. Abstain. We have Alicia Smith-Knight on the call.
I approve.
Thank you. Mary Katsikas.
I don't believe I was present at the last meeting, so I'll abstain.
Okay, thank you. Melissa Birdwell.
I would vote yes.
Thank you. Albert Richardson.
Yes.
Thank you. Amy Holland, department staff. Amy Irvin.
April. Approve, thank you.
Thank you. Ashley Jasinski. I believe you're department staff too, aren't you?
Yes, I'm department staff, so abstain.
That's a rip. Sorry, sorry about that.
You're fine.
Avis Easley, department staff. Elizabeth Reeve, department staff. Megan Gaylord.
I approve.
Thank you. Jerry Moore.
Approve.
Carrie Virgo, department staff. Kurt Hipple, department staff. Lindsay Blevins.
Yes, I approve.
Thank you. Melissa Binkley's department staff. Amy Olson.
Good morning, I approve.
Thank you. Ricky Harris.
Yes.
Steve Petty.
I vote to approve.
Thank you. And Wayne King.
I was abstained. I was not present at the last meeting.
Thank you. Did I miss anyone? All right, I'm going to hand it over to you, Ricky and Lindsay.
Thank you. Thank you. Good morning, everybody. Today is our much anticipated needs assessment discussion. We prepared a little bit for this in our November meeting with a reminder to just review the 2021 needs assessment summary, which was included in the email when Kirby sent out the agenda and the minutes as well, and a reminder about our meeting. So if you have access to that email, might want to pull that document up because we'll be referring to that for the first half of this discussion here. But since
Ricky, do you want me to share it? Sorry.
Yeah, sure.
Share it on the screen.
That would be great. That would be great. Thank you, Kirby. Since we do have a lot of department staff here, which, by the way, thank you all so much for attending and making this meeting a priority. I think the best place for us to start would be just a little bit of maybe highlight or discussion regarding some of the funding approvals, or not approvals, let me just say that funding that Governor Lee presented a couple of nights ago. And maybe it would be good to talk just a little bit about how some of that funding is targeted toward areas that we had identified in our 2021 needs assessment. So I don't know, Kurt, if you are available for just a minute to kind of highlight, because I know there are some dollars there regarding crisis services, and that was our first mental health priority, was an expansion on crisis response and stabilization for youth. So can you talk to us a little bit about that?
Yeah, absolutely, Ricky. Thanks for bringing this up. Obviously, we got some great news from the State of the State and the proposed budget that Governor Lee has sent over to the General Assembly, and they'll start doing their consideration of those items, and there will be opportunities to answer questions and get more for them to get more clarity on the proposals. But I think all in all, about almost $30 million in new dollars increases. The crisis continuum expansion, that was the one that we were hoping to place 3 new CSUs throughout the state. That was not included in the proposed budget, but it is our understanding that is being considered, and being considered very favorably in the committee that was set up to evaluate proposals for and distribute funds as it relates to the American Recovery Plan. So Commissioner Williams on a call yesterday with Ricky was on it, Albert was on it, said that she's very hopeful that budget piece will be funded through that avenue. So that's kind of where we're looking at. I think another thing that is in the proposed budget that we hope will have an impact on children's service providers, and I know that there's still some evaluations going on internally about how this would be allocated, but that cost of living adjustment in the budget request that we made back in November, the commissioner asked for a 20% rate increase. The proposed budget, we got news that there was going to be included in the proposed budget a 10% rate increase, which we're very thankful for, and we'll be looking at how that needs to be allocated across the system. And I believe on the call yesterday, Commissioner said that she's working with Matt, Rob, and Taryn to assess that. And those are kind of the two things that popped up into my head Ricky, as you were kind of wanting to focus on things that could impact children. But I'm happy to discuss other ones as well.
No, those are perfect. And just, I don't know if you have this information yet or not, but do you have any insight into whether the CSUs that you mentioned, the intention there would include children, or would that be just adults?
I don't know the answer to that question, but I can get back to you on that.
Okay. So it may be good for us to discuss a little bit as a group how to proceed strategically, whether or not we, leave this need here for 2022 as we watch the funding and, how that will play out, not knowing right now exactly whether children are included in that or not. So does anyone have any insight or thoughts about this need remaining with us for 2022 or moving in another direction?
Hey, Ricky.
Uh-huh.
It's Kirby. Just a reminder too, you all do have the option to submit 6 needs this year. So if you wanted to keep a need, but you were hesitant to because you didn't think you had enough room, just remember that as well. It's not required. It's just an option.
Great guidance. Thank you, Kirby. Other thoughts?
This is Alicia. I would definitely vote to include the need. It's still a need that's unfulfilled, and so I would vote to keep it.
Okay.
This is Mary. I would vote with Alicia to keep it. I think it's a huge gap in the children's system.
Okay.
And Ricky, this is Lindsay. I mean, I also agree. I mean, I work at a psychiatric hospital here in Memphis, and I mean, we are seeing an abundance of kids who are coming in who need services, and there are times that we can't take all of them. And we work similar to, a medical ER where they're, in our ER basically until we can find either another hospital for them to go to or whatever. And, we work in conjunction with youth villages and they help assist when the patients have TN care and things like that to find placement. But we also get an abundance of like police drop-offs for kids who are having behavioral issues, who don't necessarily meet criteria for like acute stabilization in a psychiatric hospital, but there's definite needs, for wraparound services, for trying to get them connected with a provider and things like that, that they would probably be better suited in an environment that's not a psychiatric hospital or a med surg ER or things like that. So I definitely agree we need to keep it on there.
Yeah. Carrie, I think you were on the call. Are you still here, Carrie Virgo?
Hey, Ricky. Yes, I am. And of
Yay.
course, you asked me to talk as soon as I hit the print button. So if you hear that in the background, I'm printing out some documents.
Can't hear it. I just thought you might want to speak to some of the work, and I agree with everyone that leaving this is probably the best plan, but you might want to speak to some of the work that has happened from your all's side on adding some supports in the emergency departments and kind of where you're headed with that.
Absolutely. I think the Tennessee Resiliency Project, and we had talked about this a few months ago, is now close to up and moving. Contracts are supposed to begin on February 15th. And I can say that 2 of the projects are very specifically focused on the crisis system, and that would be from the McNabb Center and Youth Villages. We'll both be expanding those continuums. And I agree with everybody on this call. We are early in that process and we've got lots more work to do. So I would agree that these probably need to stay. I can also say that Frontier is helping us to address the second one in terms of embedding a clinician into pediatric practice. With the 7 projects that are coming out of the Tennessee Resiliency Project, they're either addressing some of the school-based concerns, the early childhood concerns, as well as the crisis concerns. In addition to that, I can say at this point, SOCAT, the System of Care across Tennessee, has been able to add an additional 5 teams. So they are up to 32 teams right now that can potentially be linked to in regards to helping some of that diversion from emergency departments. So for those hard to place children and youth that are presenting at emergency departments, they can help to provide that intensive in-home service so that we can make sure that they're getting something for those who don't meet criteria for hospitalization. So I think internally we've been considering the needs assessment here as well and looking at what we can do to expand. We do also have a small grant from the National Association of State Mental Health Project Directors that is going to be focused on emergency departments as well. So we are putting some of these things in place. I think we're in a better place than we have been. I have also been working with Jennifer Armstrong over the next few months. We are putting together focus groups in which we will really want to target parents and children and youth to really tell us what kind of messaging would be helpful in understanding how the crisis system works, and what we can do to help get that message out to the very rural parts of the state. So those are just a few things that I can think of off the top of my head. Happy to answer any questions.
Thank you, Carrie. And I said it last time. I want to reiterate just how grateful we are that the department takes a look at these needs assessments and moves on these, and seeing that, Tennessee Resiliency Project money, and as you said, additional SOCAT targeted at these goals is deeply appreciated. So very excited about that. And I will say too, I think it's just a side note for our future Children's Committee meetings, but I just jotted down the ones you stated, Carrie, but having guests from, Frontier and McNabb and things like that to come as those projects get started, tell us about their local, providers that are doing the ED triage work or the ED assist work. And we want to learn more about that as we go this year. So that's exciting. Other thoughts? Sorry.
No, you're fine. I was going to say, I saw Steve Petty had his hand raised. I didn't know if that was a question.
And Ricky, I'm just going to agree with everyone that I think we need to leave it in there. We've been asking for this for several years, and I think this past year, it's unfortunate that it's taken a pandemic to get folks' attention, but we did at least get a little agreement that we need this year, and I think we've got to keep on asking until we get that.
Thank you, Steve.
Hey, Ricky, this is Mary with McNabb. First of all, we would love to present. I can tell you guys that since November 1st, we opened up a family walk-in center, and at about, probably 2 weeks ago, we had done 112 assessments for crisis that were just walk-in. So I would say that speaks to the volume of need. I will also say that Children's Hospital here in Knoxville has some really good data on the increase in numbers that are showing at their ER that are behavioral health oriented. It's pretty staggering. So in saying that, obviously I support keeping that need on our agenda, but then I will also, I think with the pandemic and just other complexities that our families have encountered over the last 2 years, I think we're seeing an acuity level that is just different when they're just even generally presenting with mental health issues, let alone crisis. So I think that complicates everything in this moment, and it continues to speak of the need, not just for CSUs, for kids that would qualify and or meet that need, but for those intensive wraparound services, even if they're time limited, to stabilize. because we're seeing a lot of instability, primarily around acuity level, and of course those factors that we've always seen for years and years and years that our families struggle with. So that just complicates everything else when the mental health piece is just more acute at this point.
Mm-hmm. Thank you, Mary. Any other discussion on this needs assessment? Sounds like we're getting agreement to keep it on the list.
I want to, yes. I think that's probably a good thing to keep on the list. I've got some new ideas too of things that we might want to consider as well.
Okay.
Yeah, and that was Megan Gaylord.
Thank you, Megan. All right, if we're good on that one, we'll move to just reviewing our second one that was on our 2021 list and see how you guys feel about that. And then we can have some discussion about any additional needs that need to make the list. Our second one was to increase and establish mental health screenings and services, including school-based services and pediatric partnerships for children up to age 8 to ensure prevention and early intervention. So let's talk about this one. I do want to share a quick story, a little anecdote, but I was really preparing for this meeting and had reviewed these needs yesterday, and a parent shared a voicemail with me last night from their child's teacher, and I listened to it, and the teacher described some bad behavior that was occurring in the classroom, and at the end of the call she said, you know, he's just really being a little jerk. And I just, I think my face turned red and steam came out of my ears, but it just reminded me that we are not there yet. As much progress as we've made, and we've made progress in this category, we still have lots of people to reach and teach about what's going on with children and how to manage their behavior in the classroom. And that made me think a lot about early childhood and early prevention work, and very excited about, again, some of the Tennessee Resiliency Project funds being geared toward young children. But how are you guys feeling about this need? Where are we? Does it need to stay on the list, or have we just made a lot of progress and we don't need it anymore? I assume that's probably not the case.
I think, this is Megan. I think there's a difference between emergent screening. Like, I think we have a really good pathway to care if someone has like an emergent need or an urgent need. I think school systems, I think daycares are all connecting people to services really well. What I think is that really looking at that prevention piece, whether it's done through pediatrics, you know, in our region 6, we've been talking about birth to 5 quite a lot. And how do we get prevention based there about mental health, child mental health, infant mental health. So I think it would be good to keep it, but I also think we've made a lot of inroads, and the department's also prioritized a lot of things to already establish that.
Mm-hmm. Does the language in this need to change at all from anyone's perspective, or are we covering the bases we intend to cover for 2022 with this language?
Ricky, this is Mary again. Can you repeat the language?
Sure. It says increase and establish mental health screenings and services, including school-based services and pediatric partnerships for infants, toddlers, and children up to age 8 to ensure prevention and early intervention for young children.
Thank you.
Mm-hmm. Taking silence as an agreement, is there anyone that thinks that this should come off of the list or be changed in any way? I don't want to leave anyone off if there's discussion.
Are we able to submit 6 as well, or are we limited?
We can do up to 6 as long. Kirby, make sure I say this right. There has to be the same amount of mental health needs as substance abuse needs, correct?
Yes.
So up to 6, but we have to have equal amounts in both categories.
I think maybe before we decide to keep, this is Lindsay, sorry, to keep both of them, I mean, I'd like to hear, I know Megan said she had some ideas. You know, maybe we should kind of hear everything and then we can kind of vote on if there are 2 or 3 or whatever that we want to move forward with, and then we can kind of make some decisions. That's just my thought.
Yeah, that sounds like a good plan. In that case, let's move into some discussion about other needs that you all would like to see on the list.
Expansion of safety. This is Megan. Expansion of safety net to include 14 days of inpatient care for children.
What's it currently, Megan? 7?
0.
I thought we had, oh no, I'm sorry. The safety net is only for outpatient, you're right.
Yep, it's only for outpatient. And it is one of the #1 deterrents to accessing care for children who have no current insurance or on safety net is that there's no way to pay for inpatient treatment. And a lot of those kids that would qualify for, and I would add to that, there also needs to be a way to get emergent safety net if the child is in active mental health crisis, because there's a lot of paperwork and it's very daunting for families in a mental health emergency to then have to walk in and provide paperwork on paperwork on paperwork on paperwork in order to get safety net when you're already experiencing a high level of crisis within the family setting. And so I think there's an issue with ease of access when it's an emergent situation, like a crisis referral. And then there's also an issue with it doesn't cover any inpatient care, unlike the adult system, which the adult safety net does cover inpatient care. And I think, if we wanted to submit numbers to the department, I think it would be a pretty low number of children who would need the service, but the impact it would have on those children and families is just instrumental.
Megan, are you sure that the adult safety, maybe someone can answer this, I don't know the answer. Does adult safety net cover acute inpatient? Because I would assume that anyone who's uninsured is just going to go to one of the regional hospitals. And so they're not coming. Sorry, did someone answer?
This is Mary with McNabb again. My understanding is that the, for lack of a better word, the menu of services for adult and children's safety net is pretty much the same, with the exception of on the children's side, family treatment was added. And I believe there's one other thing that's added that's different than the adult side that a child can receive versus an adult. So I do not remember or believe that there is a hospitalization.
Yeah, this is Kurt. I'm looking at our manual right now, and based on it, what's online, it says the BHSN operated through the department provides essential outpatient mental health services to uninsured Tennesseans. So that's the adult behavioral health safety net.
And Carrie, I might engage you one more time to talk just a little bit about, I know SOCAT is sort of a diversion focused, diversion in terms of reducing out-of-home placements, and you guys have had a lot of success with that. I know that you guys work with, lots of providers to make sure kids have access to that intensive. Do you want to say something about how that connects to maybe reducing the use of inpatient for kids?
Well, really what our hope is, Ricky, is that for those that are presenting to be in a crisis but are not necessarily meeting the criteria for hospitalization, the hope would be that we would be able to provide an alternative to hospitalization with the intensive care coordination that's in home. We are working with some residential facilities to step down back into the home with those supports in place. We've been working with DCS and juvenile justice to make sure that we're diverting from residential placements, custody, and hoping that we are working with the parents. The plan is that the family support specialists are working with the families to understand when to call crisis versus is this something that you can crisis plan for in your home. So that's really, we're hoping to help fill that, since there are so many hard to place kids out there, and there's not a lot of beds anywhere. And so the hope is that if we can put that intensive in-home service in place, that we'll be able to kind of cover that gap. Is that what you were looking for, Ricky?
Yes, thank you. So Megan, you're really kind of pointing out to a problem with access to outpatient or inpatient or residential care for kids. Is that kind of where you're
not residential, just inpatient psychiatric, because we do not have state hospitals for children. We have to negotiate with private hospitals to be willing to either take a case of charity or hand a family who we know is lower SCS a substantial hospital bill for their child's mental health treatment. And so in terms of SOCAD, I'd second, it's great if the person is stable to have that service. If someone is acutely suicidal or homicidal, SOCAD is not the referral option that we can give them in the moment. And so a lot of times kids with no insurance sometimes will sit in a hospital boarding for a period of time until we can get someone to accept them without insurance. And so that means that they're sitting, taking up a medical hospital bed while awaiting an inpatient psychiatric bed, while someone plays hot potato, while we have private hospitals playing hot potato with a Tennessean child. When if we had, because we have no state hospitals, 7 to 14 days of inpatient care as part of safety net, I think we would just eliminate the ease of access issue. Sure. The second ease of access issue has to do with if someone walks into a mental health center and maybe we have some issues with ADHD or depression, I need some services. Sure, they are not in active crisis. They can bring in all that paperwork. They can figure out transportation, versus they're in a situation where maybe their child is suicidal or maybe they've made a serious threat. We need to identify a way to cut through some of the paperwork in order to get people access to safety net services more quickly. Whether it's if there's a crisis continuum contact, that they would automatically be eligible for 30 days of safety net before they have to provide all the documentation, because that gives that provider 30 days to work with that family to get everything they need to submit the application.
Okay. So I'm thinking the language for the first one might be something like the need would be to increase access to inpatient psychiatric services for children and youth. And then the data obviously to go with that. But does that sound right, Megan, for the first one that you're suggesting?
Correct.
Okay.
Correct.
Others that would support that need or any discussion around that idea?
This is Lindsay again. I mean, I definitely agree. You know, in West Tennessee, you know, specifically through youth villages, the private hospitals, which there's only 2, rotate, you know, taking the indigent kids who need access to, you know, the acute stabilization level of care. But we also see a lot of kids who just walk into our ER as well, who don't have insurance, meet qualifications for TIN care and things like that, and we help them, you know, help the families apply, because like Megan's saying, if they've got, you know, access to TIN care, then that opens up a lot of doors for them, for us to be able to refer outpatient and step them down for them to be successful back out in the community. So you know, I think it would be helpful for them and hopefully keep them out of continued crisis if we can get them, you know, obviously access to acute, but then also quicker access to safety net as well.
Okay. Kurt, on the question about or the need around quicker access to safety net, is that something that maybe we could take back to the department for some discussion to see if there's anything we can do to improve that process or that paperwork process for emergency situations.
Absolutely. I mean, we have a children's behavioral health safety net now, and you know, I think it's worth exploring that way, because we've seen in the past with the adult behavioral health safety net where services have been added. You know, when funding is available within the allocation that was made. I'm thinking of what comes most top to mind is transportation being added as a covered service a few years ago. So I think that could be an avenue, and certainly happy to help facilitate that conversation with Matt, Rob, and Katie Lee. Just let me know.
Okay.
I'm gonna chime in. A good alternative, there are state grant beds. However, they are only in East Tennessee and they are limited to, I think, 2 slots per hospital. And I think it's in conjunction with adults. The other thing might be that we ask the department to open an RFP for grant beds that could be equilaterally split between middle, west, and east. I don't know if that would be something, you know, that we could also suggest, like, there's this need, but then there's also this potential alternative solution. Because I know when we talk to our private hospital partners out here, when we look at inpatient psychiatric care, the question is kind of like, how do we get some of those grant beds out here? And the question is, I don't know, because I don't know how the hospitals in East Tennessee got the grant beds to begin with. And I think it's Woodridge and I think Valley that has the only grant beds in the state that pediatrics can go to. And that's asking a lot for a kid from Memphis with no insurance to go across the state in order to get inpatient psychiatric care in a way that's going to make sure that that family isn't stuck with a very large bill.
Yeah. That makes sense. How would you all like to see the concern around the safety net paperwork? Would you like to see that listed as a need, or would you prefer that I take that for discussion with department staff? I'm happy to do either.
This is Lindsay again. Which do we think might heed greater results? I guess is the question. Is it better served being on something like this, or just taking it back for discussion?
I will just say that, you know, at putting off my Children's Committee chair hat and my Tennessee Voices CEO hat, we're new providers in the safety net, and just my work with Katie Lee and her team and Rob as well have been very easy to talk to and open to discussion around the use of safety net and kind of how things are going, and seem, in my opinion, eager to ensure that we're making it accessible. So I would be comfortable going back and talking to them, but again, putting my chair hat back on, want to do whatever the group feels is the best next step.
Wayne King here. I think the discussion component would probably be the best venue currently, because we need to figure out what can be streamlined and what needs to be enhanced as far as the paperwork to ensure a swift and safe entry into the system.
Mm-hmm.
Yeah, this is Lindsay. I think I'd be in agreement, you know, if we just move that towards discussion versus listing it on the needs assessment. We might get quicker results too, or
sure,
more fruitful conversation right now.
Ricky, this is Mary. I agree with that. I think it would be a discussion topic, and I think it could, you know, with all the probably details and system flows, it's probably worthy of a discussion, just putting it on the needs.
I think so. And Alicia, I know you're here, not to put you on the spot, but if it's something you'd be willing to talk to the children's group at TAMHO about and get their feedback, that would be helpful too.
Absolutely.
Okay, great. Lindsay, I know you're going to cover the substance use needs, and I don't want to run us out of time. So I'd like to transition to substance use, but I don't want to neglect any other thoughts or burning needs that you all think need to be included in the mental health section. Any other things that you guys want to throw out there before we shift gears to talk about substance use? Okay, then Lindsay, I'll turn it over to you.
Thanks. Yes, I didn't realize how late it was getting already. So, okay, so I don't see it anymore. Kirby, did you take down the,
I did. I'll put it back up.
Okay, so we had 2 substance abuse needs from last year that we submitted, and I'll just start with reading both of them, and then we can kind of have, I think, discussions about both. Just for sake of time, I think we need to move a little bit quicker. So the first one that we submitted was increasing access to home-based substance abuse services for mothers with young children. We had talked about in that discussion about it, the, lack of opportunity for mothers with kids to get treatment services without having to separate and things of that nature. And so we had wanted to increase opportunities for home-based care, whether that was actual in-home or telehealth services for substance abuse services or treatment. The second need that we had discussed was expanding upon and provide more access to intensive outpatient or IOP substance abuse treatment programs for youth, to include telehealth services for youth in rural Tennessee. And part of that discussion, we had talked about the increase in utilization of alcohol and drugs for teens, specifically in the rural parts of the state, and not a lot of opportunity for them to access any sort of intensive outpatient services to meet the needs that they have out there. So, obviously with the pandemic and things like that, I think there have been some providers that have increased telehealth over the past couple of years, but definitely I think still a need there for that. So I'm not sure who of y'all were on the conversation from last year, but what are your guys' thoughts about some substance abuse? Do we want to keep these? Is there new needs that we need to be conversing about?
Wayne King here on the expand upon the intensive outpatient substance abuse treatment. One of the things we're seeing here in Scott, and I'm sure it's across the state, is a large increase in vaping, a huge increase in vaping. I do tobacco classes, which now include vaping, and all the students that I have in my class right now are for vaping. None of them are for actual tobacco use, which is a big gateway, even compared to tobacco use. So is there some way we can include that, especially in the rural areas anyway?
I've actually been hearing a lot about the need for education around vaping for our young people. It's definitely, continuing every year to increase. What about the rest of y'all across the state?
This is Melissa. I can speak to that too. We do see a huge need for information and treatment around vaping, but we are also, especially in our IOP program, seeing a lot of need for treatment around the heavier, I would say, drugs, cocaine, meth use. Most of the kids we have polysubstance use disorders. So I would say any kind of expansion of IOP, whether telehealth or otherwise, would be a very good thing at this point.
This is Alicia. I would agree with that.
This Wayne King again. Yes, I agree.
So, I mean, I guess the question then is, does the wording on this one seem okay? Because it specifically is talking about kids in rural parts of the state. And I'm in Memphis, obviously, and there's a lot of different IOP programs, more specifically for mental health or co-occurring than straight substance use. Most of the time, obviously, some of them are going hand in hand. But do you guys think that if we need to keep this need on here, is the verbiage what we want to keep?
So this is Alicia. The way I read it is we need more IOP access, and we need for that to include a telehealth option, especially for those in rural Tennessee. That's kind of how I read it.
Okay.
But
I just want to make sure that the way that it's worded, everyone is continuing to be in agreement with. I mean, obviously to include telehealth. So yes, I mean, I agree with you. It could be for all kids, expand services, in addition to the rural west part for telehealth. And I'm pretty sure at this point, all insurance companies are reimbursing for telehealth, so there isn't an issue with that. It might be education and making sure that everyone in the rural areas knows how to access the options, including telehealth, if there's a provider that can treat them somewhere. The problem that I think
this is Megan. I was going to suggest adding one thing. So Region 6 has seen an expansion of IOP telehealth that's been very successful. The barrier that we're running into is consistent internet access or reliable internet access for multiple hours of streaming to do it. So we actually have a model at one of our high schools that would be very successful, which is to introduce school-based IOP. And it is embedded in a public high school. It has been a highly successful program that has been run by one of the mental health centers for more than a decade. And so maybe adding the language to include telehealth services or school-based IOP.
So are they running that program during school hours?
They are.
Okay. Who's doing it?
Quinco is running it through Riverside High School.
Riverside?
And it has been highly successful.
Yeah, you make a very valid point with the internet reliability and things of that nature. So maybe we can add to include telehealth services for youth in rural West Tennessee and school-based programming or something like that. So we can work on how to add the school piece into it for sure. Now, is it a funding issue, you think, though, or resistance on someone's part to do some of these things? I mean, I don't know how Quinco and Riverside kind of got started with all of that, what you're saying a decade ago, but are there other barriers? If telehealth services are around, do we just not have enough programs to meet those needs? Is it an access issue?
This is Mary. I definitely think I have kind of two comments. I definitely think it's an access issue. Like, for example, we have an IOP and we're having to get kids into Knox County from surrounding counties because there's no access in surrounding counties. So I do think the language needs to include an expansion of. And then my second comment is there a reason why we're putting rural West Tennessee in the language?
It doesn't say rural West. It just says rural Tennessee. So non-urban areas. Okay. It doesn't say rural West specifically.
Okay. I thought you said West in there earlier. My bad.
If I did, I apologize. I'm from over here. And so usually when I say rural, West comes after it, but no, it just specifically says rural Tennessee.
I get it.
Did you have another comment too, or were those the two?
No, those were the two.
Okay. All right, for sake of time, does anyone else have any other comments on the IOP services? It sounds like we need to keep it pretty vague in the sense of it could include vaping and or other, polysubstance use. We can add some school-based language in there as well. And it already says expand. So we'll make sure that we keep that in there to make sure that we're continuing the expansion of that. The second one that we had was increasing access to home-based services or substance abuse services for mothers with young children. Is that something that y'all want to keep on here, or are there other ideas of different needs that we might have? And keep in mind, we do potentially have 3 mental health needs, so we could do 3 for substance abuse as well.
Wayne King again. Do we want to limit that for just mothers with young children? What about maybe single fathers with young children?
Yeah, I'm trying to read through the data that we had. I mean, when I'm looking at the data specifically, it looks like it's all inclusive. It doesn't specify females only. And so we could, if everyone's in agreement, or if you all want to change the language, we could just say, parents.
Yeah.
With young children.
I agree.
Make it more inclusive.
I agree with that. Change the language there.
Do you guys feel like that's still a need across the state?
I would say, based on statistics, we're looking at substance use during pandemic. I would definitely say that's an issue.
Agree. This is Mary, and I would also agree. I think treatment options where parents are separated from their children are there's not that many opportunities where parents aren't separated from their children. So I definitely think it's a need. And I'm in agreement with changing the language just because I think parents can look differently.
Okay, and do we feel like the need is more for home-based services? And I see in the data it says telehealth as well. Or are we looking at expanding that to opportunities for, out-of-home treatment with being able to bring the children? Can you all hear me?
Yeah, I know. I did some research on pandemic and substance use. It's outside my wheelhouse, but what they found was that specifically moving to telehealth and home-based services had a very strong impact over a lot of clinic-based services.
Mm-hmm.
We might want to add language to include home visiting services for like MAT for medication-assisted therapies. There have been some pilots run outside of Tennessee with high effectiveness of shifting some of the law and language around Suboxone and that type of treatment, and doing that in a home visiting setting to help increase compliance and also decrease the reliance upon like transportation issues.
Mm-hmm.
So I know there's data around that.
Okay. I know what else we and I'm not sure if what funding looks like for it, but I know we have had several staff, our peer support specialists who worked, in the acute setting, and in our outpatient services have gone and are now working for companies that do provide telehealth services and or in-home services at a peer support specialist level, specifically to support, parents with kids and things like that. So, I do think that it's important to notate the home-based / telehealth in the need, since we mention it down in the data. What are the rest of y'all's thoughts about looking at like MAT or Suboxone in-home treatment? I don't know of any current providers that are doing it, but I also haven't done a lot of research on MAT in that regard.
This is Alicia. I would just say for me, this is a discussion that I feel is much bigger than what I could provide here. And I don't know that I would feel comfortable putting that as a potential need without more information from, the substance use providers.
Do we have any specific substance abuse providers on the call today?
Lindsay McNabb provides substance use in a variety of services. This is Mary again. I am in agreement with Alicia, though. I think MAT, is still shaky ground for a lot of individuals. And I think, there's a best practice model out there for the types of services that need to be added for someone receiving MAT. So I just don't know that I feel comfortable recommending or supporting an in-home type of treatment with MAT until, we've got some more time around rolling out MAT across the state. I mean, it's kind of a new service array that I think organizations are really getting into at this point.
Yeah, I agree. I mean, mostly what we're seeing over here is the MAT clinics are working in conjunction with providing IOP level of care at minimum. So in person, so it's intensive outpatient with the MAT. So what I'm hearing y'all say, since it's 9:59, is that we want to keep the need similar as written, but add telehealth services in there as well, and change mothers to parents to be inclusive of moms and dads.
Yes.
All right, thank you. Otherwise, I'll take the silence as agreement. All right, so we'll get those reworded. Yeah. Kirby, Ricky.
I was just going to say, I know we're out of time. If we're going to add a third mental health, I'd suggest adding a third substance abuse around. Everything's about ease of access today. Right now, if an adolescent wants to have treatment for addiction and they need residential or detox, there are very little same day or immediate options. We're seeing that typically, they're having to wait on bed space. It can be a 14-day wait. They don't meet criteria for inpatient care. We really only have one inpatient hospital that will take detox for adolescents in the entire state. So I think we need to look at, that is Lakeside.
Okay. I was like, we do.
You're the only one in the state that will take an adolescent for detox. And so, as we pointed out, our kids are using harder and harder and harder substances than we were potentially seeing pre-pandemic. And I think we need to develop a need priority based on how to get an adolescent into more emergent residential alcohol and drug treatment. And the need is even greater if you happen to be female in Tennessee, because there are even fewer female residential beds than there are male beds for addiction.
Megan, is that true? I mean, is that specific to children, that there are more for male children?
Yes.
Okay. Wow.
There it is hard to find. Trying to help a parent find help for their female teenager who needs residential. I can't tell you how many places I call and it's like, great, we don't take women, we don't take girls, you know, or they've only recently established their program, or their program is full. And it just seemed like it was harder to find places that took young women, or they have a disproportionately higher number of male beds than they do female beds if they take both. So I think that was one of the things we ran into. But if a kid says today, I want to get help, I want to stop using, there's a strong chance they're going to change their mind 14 days later and or run away in the process.
Right.
And so if they don't meet inpatient criteria, we're kind of stuck where it's like, put in a plan as best as we can and hopefully get them assessed and in. And we have some facilities that'll tell us they can't even do an assessment for insurance pre-authorization for 14 days, let alone if they're going to have a bed in 14 days. So I know that I don't work in the adult system, I work with the kids, but trying to find a way that we can, either there's an RFP to earmark funding for emergency beds that they would, you know, or find a way to do like emergency census allowance that they might be able to temporarily go over census. You know, I don't know how to put that into a need, but that's what the need is itself, or what we would be able to ask the department to be able to action on that.
Okay. Lindsay, that's something we can kind of tease out, and then once we get all this down, and we can send it back out to the group to review all of these ideas and things that we've decided to get on the list today, if that's good with you all.
Hey, Ricky, this is Kurt. I wanted to follow back up. I heard back from mental health services. The proposal, the budget proposal around the CSUs is adult only. So I wanted y'all to have that information as y'all consider these needs. And I would just also say that a reminder that this department is funded to serve individuals without insurance or who are indigent. And I know in a lot of the cases, children are going to have, you know, either there's going to be a large percent of them that are covered by TennCare. There's going to be a large percent of them that might be covered by their parents' insurance. But we have tried to address that gap with the Children's Behavioral Health Safety Net and other issues or other programs. But just keep that in mind as y'all are deliberating.
Thank you, Kurt. That's a good reminder, and thanks for grabbing that information so quickly for us. All right, I know we're at time, and so we need to adjourn. I just want to thank everybody so much for attending this call. This has been one of our best attended calls. Thank you for the discussion. Really helpful, and I appreciate all the department staff who participated today along with us. Again, thank you, and hope you guys have a great rest of your week.
Ricky?
Yep.
Sorry, before you end. So with these needs, so we'll have to vote on these needs. And I know that you all are working on gathering a lot of them first. So when the time comes that they're all put together and you need approval, you can do that via email. So you can submit whatever you plan to submit to me. We can share it with the Children's Committee to vote on before it's officially sent to me.
That
Just
sounds
a
great.
heads up.
Yeah, I love that. Thank you. All right. Any other reminders or last minute things? Great. You all have a great week.
Thanks, Ricky. Bye, everybody.
Bye, everyone.
Bye.
So,
Good work.